Good morning. My name is Amy Berman, and I'm a Senior Program Officer with the John A. Hartford Foundation in New York, a foundation focused on improving the care of older adults. I'm in front of you today with two other seats, and I will be talking to some of our panelists individually, and we will be having a conversation, a deeply human conversation between people who received care and the providers of their care, followed by a person who does research about the things beyond clinical care that are so important to improving the lives of people experiencing serious illness through the end of life. I'm also a person who is terminally ill. I live with advanced illness. So I'm coming at this session from a place of great honesty and respect and keen appreciation for the difficulty of people sharing their story, the most difficult times in their life, sharing what was helpful, what wasn't helpful, the obstacles that they found along the way. But this opening session also is a story about transformation. Because in both of the cases, the pairs of people that we're going to hear from, the clinician was a clinician before palliative care, and it transformed them, their experience with the person that they're sitting with. So this is an amazing opportunity to hear what the meaning is of palliative care and good care in serious illness and end of life. So this session is on integrating the patient, caregiver, and family voice in person-centered care. I think about it as people and families and how to integrate their needs into their most difficult time, and how do we support them through this difficult place. As Rebecca mentioned when she started this morning, it is ultimately around the people that we care for. And so that's why the framing of this session is so important. I wanted to start by asking a little bit about you. I told you a little bit about me. So I want to find out from the people who are here, how many of you are from the policy world? How many are from clinical practice? How many from social services? How many from gaming and other forms of innovation? How many from spirituality? And how many more are here as people who have had an experience in their family? And that can be a second hat that we all wear. This is important. Every single person has had an experience, a deeply human experience that connects us all. And oftentimes when we do the work that we do in policy and practice, we take off that hat. Today, I'm hoping that you integrate it in every cell in your body, because that's really what it takes to do things right. I'm hugely admiring of the people who are in this room. I know many of them, and they are my heroes and sheroes. Our panelists in particular, two of which I have known and admired forever, and three of which are my new best friends. I wanted to also go over briefly the landscape around serious illness and end of life, just to give you an update of the context for this session. We have a new administration. We don't know what that will yet mean. We don't know yet what the perspective is, not only of our president, but new members of Congress, new staffers. We will have radical change, which can be an opportunity, and I'm hoping it can be an opportunity. But it is a time of change, and that raises concerns in all of us. This is the kind of session that I hope will help inform, and the written report that comes out of this, we hope will be beneficial in further informing the administration. We also know that in the pop culture, there is an increasing number of books and speakers. I'm thinking of great people like Atul Gawande and his book Being Mortal, When Breath Becomes Air, written by Paul Kalanithi and finished by his lovely wife, Lucy. And many, many other things that are going on in the pop gestalt. People care about their life and the choices that they get to make in their life. They are increasingly demanding care that fits their desires, their goals, their values. At the same time, we haven't, up until this year, had a way to pay for these conversations. So one major change is that there are 2 payment codes that allow us to pay for advanced care planning. One of our sessions today will talk about some of that and what it can't cover, and perhaps how far it will need to go to be able to reach the people who most need this kind of care. And while Rebecca shared with us that we are focused on living well with serious illness, there is a range of opinion about something called medical aid in dying. This is not where I choose to spend my personal focus. I also, like Rebecca, focus on living well in the face of terminal illness through the end of my life. But this is part of the landscape. So medical aid in dying is when a terminally ill, mentally capable person who has a prognosis of 6 months or less to live requests, obtains, and if his or her suffering becomes unbearable, self-administers medication that brings about a peaceful death. Prior to providing a prescription for such medication, doctors must confirm that the person is fully informed and provide the person with information about additional end-of-life options, including comfort care, hospice, and pain control. This is currently authorized in 5 states, either through statute or court decision, and those are Washington, Montana, Vermont, and California, and Oregon. Oregon was the first. I'm just saying this, that the range of things that are going on in this country are moving in a direction. The public, 70% want to die at home, and yet 70% still are not able to die at home. They die in ICUs and typical high-tech settings. My foundation did a survey of providers to ask them around end-of-life care, what they're doing with these advanced care planning codes, for example. 99% said that they believed that this was part of their job to have these conversations. 99% of providers don't agree on anything. But unfortunately, roughly half of them said they just don't know what to say. The providers who I'm going to call up here knew exactly what to say. Without the training, they are examples for the nation.